This is important because hip instability is still the number one cause of revision total hips. It's also the number one cause of re-revision total hips, and more so than even infection. So this really needs to get the proper deserved attention. But if you look at all the revisions that we did a series where we looked at 380 revisions, and we really critically analyzed the surgeries that were done and figured out why we were revising them. We had 3 different surgeons who all opined on it, and we found that 51% were potentially avoidable had the first one just been done properly. So the best way to avoid a revision surgery is just do the first surgery properly. The most common reasons that we found were suboptimal positioning of the components, intraoperative fractures that were missed, and then early aseptic loosening, either due to stem choice or picking the wrong stem for the wrong bone. So very sobering results, and I think we need to think about this in our primary setting. But when you dive down, it's really 48% of these were suboptimal positioning of the components. So figuring out where to put these parts better for particular patients is where you can really figure out how to do this better. Who's at risk? Medicare database showed if you do a 1 or 2 level spine fusion, you increase your dislocation risk by double. If you have a 3 or more level spine fusion, you're almost 5 times that risk. So clearly a group of patients that are at risk. If you think about Sorry, I lost the thing. Mayo Clinic's also been looking at this. They found lumbar fusions to the sacrum increase the dislocation rate, and they also found that if you have a big, on your post-op x-rays or on your pre-op x-rays even, if you have a large posterior pelvic tilt or you're looking at an outlet view that you would remember from trauma, that's the highest risk for dislocations, and I would agree that's a significant sign of a spine deformity. So look for this type of x-ray. You've got an outlet view on your pre-op imaging. That's a person that's at risk. We did a similar study here. We looked at an institutional database of a spine and scoliosis group, higher dislocation rates and spine deformity, so 8% versus 1.5%. So very, very high-risk group of patients that you need to identify. You may think you don't see this at all in your practice. However, it's about 18% of the population that you see. This was done in over 9,000 patients. 18% had spine deformities. So if you do just some simple math here, 18% prevalence, 8% dislocation rate, close to the 1.5% dislocation rate that you see in the literature for dislocations. So clearly the highest group is that spine deformity group. And they're also the highest group in these revisions for dislocations. We looked at a series of dislocators that we revised, and 75% of them actually had spine deformities or some significant spinal risk factors. So this puts you really thinking about maybe this can be prevented, and it's not something that you can just ignore. Our workup has been very simplified. 2 x-rays. Maybe you probably only just need 1 x-ray, the standing lateral x-ray. And you really just need to look at the 2 lines, the anterior pelvic plane and the sacrum. If that anterior pelvic plane is straight up and down, you're going to be okay. If it's tilting post-anterior here, that's a hip flexion contracture, you're going to be okay. And the one thing to remember is if you look at that far picture on the right, if you have a posterior pelvic tilt, that's the spine deformity. That's the highest risk patient. That's what's giving you the Mayo patient that has a large posterior pelvic tilt. That's the one that's going to be fused to the sacrum if they have a spine surgery. So that's the one, if you only remember one thing from this talk, it's that picture on the right. If you see a posterior pelvic tilt, that's the one you should be aware about. And then you can get your standing and sitting x-rays, and you're just looking at whether the sacrum changes or not. You can see here it doesn't change, and you can see over here that this is a person with a spine deformity. We've looked at the case control series 1,000 versus 1,000 pre and post protocol, showed significant dislocation rate reductions in this group. We've also looked at this prospectively in 3,000 patients. Same thing, 99.2% survivorship. So otherwise an 8% dislocation rate and doing very well having just looked at this. The same thing goes for revision surgery. When you're revising hips for dislocations, you need to think about the spine because 77% of the time, this was a series of 111 revisions for instability, 77% of the time the supine x-ray looks absolutely perfect. And then when you start getting your lateral x-rays or your standing x-rays, the cup was in a completely wrong position. Just like this case here, right hip replacement done. She was dislocating within 2 weeks after her surgery. Right, 2 weeks dislocated, 2 days later dislocated again. I got a call from a hip surgeon who's been in practice for 25 years, and he couldn't figure out what to do with this because it's clearly a problem. When you look at that supine x-ray, everything looks just okay. When you look at her standing x-ray, it's a completely different spot. Right? If you're trying to make all your decisions based on that supine x-ray, you would not know what to do. You might have increased the head length, you might have changed it to a dual mobility, but you probably couldn't because of the sup size here. So you have to confirm this on a standing x-ray if you can, if the patient can be stable long enough to get a standing x-ray, but you have to also look on a standing lateral view. And you can see she's got that large posterior pelvic tilt. So identifying this preoperatively will actually guide your treatment. Otherwise, you would have done something that wouldn't have solved the problem. So I revised her, given her big spine deformity, to 31-12, which is a position you think is absolutely crazy, but when she stands up, it's right in the perfect spot, a 40, and a little bit higher on our anteversion of 28. So you really need to think about this in all the dislocating hips, because like I said, 75% of the time you think it's going to be okay, but it's not once you start looking at it. Here's the same exact case, except now we're preventing this before we start. 73-year-old left hip arthritis. She's got previous spine surgery, but no fusions. When you get a standing x-ray, you can see a large posterior pelvic tilt, really different than her supine x-ray. So you need to start thinking about this. You can easily identify this just with appropriate imaging. Get that standing x-ray, again, large posterior pelvic tilt. Same thing the Mayo papers were talking about, same thing we're talking about with spine deformities. Look for that, and that's when you need to do something differently. This is why it's a problem. Look at the middle picture. You've got that large posterior pelvic tilt. Your cup is going to be wide open. Right, the cup's attached to the pelvis if you do a good job with your hip replacement, and the cup is going to be wide open in a completely different position that you thought you were putting it in. So if you can understand this concept, you've got probably the most complicated part of the whole hip-spine relationship. Just look for that posterior pelvic tilt, especially in the revision settings. So this was the highest risk group. We went to a dual mobility. We increased our offset slightly, and we treated it as a high-risk protocol. And now the same case that you just saw previously has been prevented, right? We prevented the instability for that particular patient. So in conclusion, I think you really need to think about this, especially when you're revising hips for instability, because 77% of the time when you think things are appropriately positioned, they're actually not for that particular patient. And dual mobility does not fix all situations. We had a 3% dislocation rate in our revisions for instability using dual mobilities. So it's not the answer for everything. These are complex problems and need to be treated as such. So thanks for your attention.